So I'm going to try not to talk for too long. The slides are fairly simple. If you've got questions as we go along, put them in the chat box for Michael. But I will come in due course to some questions that I'm going to put out to you to get your responses to. So I'm going to start to go through the slides now. The first is about the strategic context. We circulated a paper on this, but I'm not relying on the fact that you've all read it. The reason that we felt a need to review our strategy was twofold. The first main reason is that we were founded nearly 10 years ago, and the world was quite different then. There was an assumption that we would be working as an interface between our member charities and national policy, but national policy then meant the Department of Health and ministers and various teams of civil servants there. That's really very different now. In fact, the DH is making very little policy indeed. And so the second assumption, that we would be a strategic partner with the Department of Health, has also come under question. We were a formal strategic partner. That arrangement was then further widened to be a partner to NHS England and Public Health England as well. And we're still a part of something like that. It's now called the Health and Wellbeing Alliance. It's been somewhat reduced. But of course, there are also lots of other national bodies, all of whom need to come into alignment to sort of get the sorts of things we want. So there's regulators, there's NHS improvement, and so on and so forth. The third assumption was that a big chunk of our funding, initially it was about half, and then we managed it down to a third, but that would come directly from a central grant from the Department of Health. Now, that became channeled through the Strategic Partners Programme, and when that programme changed this year, that funding was significantly cut from £200,000 a year to £60,000 as core funding. So again, things have changed significantly. And finally, we were set up with a mission to work around voice, to raise the voices of patient service users and carers and of organisations working with them. But over time, we began to look at okay, there's a problem with sound for one user. Can others just register if they're having a problem? Meanwhile, I will speak up. Yeah, we turned that voice mission into something else. It's like, what did we want those voices raised for? Well, whenever we discussed with members, what they wanted was a new approach to care design, looking at person-centered care. So a lot has changed in our own mission and organisation. But of course, secondly, the whole environment around us has changed. Policy is no longer made by a single centre in the Department of Health. It's become very fragmented, not just among the national bodies, but also because a lot of it is devolved downwards now. So we've had integration pioneers and vanguards and STPs who are really kind of trying to set the tone for what happens in their locality or region. And as that has happened, it's also blurred the lines between policy and practice. It's hard to know where one stops and the other begins. And of course, around the mission for person-centered care, quite a lot has moved on there. I mean, we feel we've had quite a lot of success collectively as a coalition in promoting those messages and those interventions. The question is how we move on now that we've made some of that impact. So that's the strategic context, and I shall ask you later whether that makes sense to you. We're actually conducting 2 reviews, but we're focusing on the first of these today. The one we're doing, as I say, is our influencing strategy for the next 2 financial years to go in our business planning. And this very much starts from where we are now, the team that we have, the types of work that we have already been doing, following up achievements by trying to take them further, and looking at what's next for person-centred and community-based care, where we can have most impact to push that further, and who we should work with, all questions that will come up later. But I just wanted to note also that because we've realised so much has changed in the last 9 years, we're also starting another kind of review, which is more a fundamental review of the organisation itself. And that doesn't start from where we are now. It starts from thinking, where will we need to be in 5 years' time if we're going to continue to be successful in mainstreaming person-centred care? And what kind of organisation would we need to be then? And how would we get the funding that we'll require? So, you know, those are sort of much bigger questions, and we're only just starting to organise the way that we review them. For today, though, I wanted to start with the fact that already during this year, as we've started the influencing strategy review, we've adjusted our model of change. So we're a coalition of health and care charities working together. We stand for people being in control of their health and care. In order for that to happen, we're pursuing person-centred care. And what we've changed somewhat are the communities that we seek to target to work with. So the first is politicians and national system leaders. That's as it has always been. The second we now are speaking of as frontline reformers. So previously we kind of thought, well, local leaders of health systems, people like pioneer boards or vanguards. There's something else really, though, that's going on, which are kind of networks and groups of people who are taking change into their own hands, may not be formally a part of those restructures of the health system. So we're thinking here of things like GP federations or some of the social media campaigning that's been done, like Hello, My Name Is, or We Nurses. The third group, and we have wanted to target these before, are professional leaders and organisations. I think it's fair to say we've not done enough here because most of our capacity has been sucked into the national policy. We want to rebalance that a bit. And then finally, what we've now described as civil society activists. So previously we'd have said charities, essentially, people in our sector, that's you, our members, and others, allies, and we still want to work with all of them. Our friends in NAVCA and Volunteering Matters, for instance, who we have a consortium with, the other organisations in the National Health and Wellbeing Alliance. But I think we also want to be able to include local health watches, people like the Patients Association, Picker Institute Europe, and again, other networks that are arising now that are trying to push boundaries of personalisation forwards. So how do we want to work with those constituencies? Well, these are the proposals in the influencing strategy, and I've emphasised the word proposes because this is what we're testing out with you. We want to know if this is where to go. So we're proposing that we continue working at national level and taking the best opportunities to have some impact on policy, but we're not going to commit so much of our policy resource to that level of working because the conditions for partnership have really become less and less promising in the last couple of years, partly to do with the way that the NHS is now so screwed down to trying to deliver on the financial targets. So, secondly, we're also taking something of a step back from the national partner bodies and kind of making sure we still have a position of independence and that we're able to challenge them when we need to, either because they are burying the person-centered care stuff under other priorities or for other reasons. And tomorrow there's an NHS England board meeting. They say they're going to talk about difficult decisions that they now have to take given the budget wasn't adequate. Difficult decisions, of course, is code for rationing. And already we've seen rationing happening at different levels. So that's one way in which we need to stand outside a little bit and kind of hold their feet to the fire. Third, as indicated by the previous slide, we're looking for change makers, people a bit closer to the front line, to local regional systems, who might be keen now to pick up on the person-centered care stuff and actually run it into the way that care is designed. So, for instance, we're talking to some of the academic health science networks, which have a regional brief, which are becoming much more oriented now away from, not away from, but in addition to their sort of academic research and innovation, also supporting their systems locally to develop. We want to talk to the GP federations and the network that's called the Primary Care Home, who are actually not waiting for policy to change and are, working towards new ways of delivering primary care. And as I noted earlier, we want to spread culture change by working through professional networks because those are somewhat more durable than the churn of policy and the churn of organizational structures in the NHS. So those set the kind of broad outlines of the things that we've been thinking about, and I want to really start asking those of you who are on the webinar for your views and comments. I'll ask. I'll just pause a moment and ask Michael to come back in and suggest how people can comment into this.
Yeah, so I'm just going to start a survey to see if people have the ability to be seen and be heard. So just bear with me 1 second while I get this up and running. Just 1 second, sorry. Okay. So if you've got a mic and a camera and you're able to actually be seen and heard, just let us know. Okay, so there's a few people that do. If there's anyone that has a mic and a camera and they would like to ask a question or speak at this stage, you're able to put your hand up to let me know. You can see that there's a smiley face just above the chat box where you'll have that ability. So you can put your hand up and we can give you the screen for a minute then. Otherwise, if you want to type any questions into the chat box, I can read them out on your behalf for everyone. Doesn't seem to be any questions coming through yet. So we've got Ian Silver has come through on the chat box, Don, to say that do NV see a role in supporting voluntary organisations to deliver against policy and influence at a national level to help organisations on the ground delivering services? Policy is great, but delivering best practice examples of implementing policy on the ground is challenging. No recognised way of evaluating self-management and person-centred care nationally. Information governance issues GDPR issues, lack of resource in primary care, etc. Policy seems to be consistently breakdown at the level of delivery. We strive to deliver and evaluate examples of best practice, but this is becoming increasingly challenging in a fragmented health system. Thanks, Ian.
Yeah, Ian, I mean, all of that is true, I'm sure. And we definitely want to work with members. I think that's in our fourth box, really, which is the civil society box. And I think we are, to give you an example, well, a lot of work we've done over the last 3 years was done through the Wellbeing Our Way program, where we hosted communities of practice around some of the person-centred care interventions, so that members and other voluntary sector organisations and experts by experience could all come together and learn from each other about this, including learning about models of change and impact and evaluation and so on. Of course, the WOW program's closed, but because we've developed that way of working, we'd like to do more of that with members, and we're here to hear suggestions from you all about topics or areas in which you might like to do that. The ones we're looking at the moment are inequalities, where we had a recent members workshop to think about what we could do in the space of looking at how voluntary sector can reach underserved communities and diverse groups of service users. We hope to develop that in due course into a proposed work stream. We're also continuing to do work on peer support, which flowed out of the WOW work. And at the moment, my colleague Hannah is scoping the possibilities for setting up a portal for real practical resources on how to establish, how to develop, how to improve peer support provision, collecting resources which often disappear when people have done their program reports and their evaluations. Those things often sort of become hard for others to find afterwards. So we want to do that as a kind of open source portal, but that's all in development. So I think those things are definitely there. I mean, one of the things that we do with our consortium Voluntary Voices, which is with NAVCA and Volunteering Matters. NAVCA is a local voluntary sector infrastructure body. So all the councils for voluntary service are NAVCA members. So we use that grouping often to try and do localized work that spreads some of these approaches. And we've done 27 meetings around the country in the last year on personal health budgets, and we'll probably follow those up with some further targeted work next year. So the broad answer, Ian, is yes, and there is an open invitation for suggestions for where you'd like us to sort of host that kind of shared learning.
Thanks for that, Don. I'm aware that we actually may need to change mode to allow people to raise their hands, so I'm going to try that. It may sign out your video for a second, so if it does, you'll have to sign back in. Just be aware, okay? It just takes one. No, we're now in Q&A mode, so people who have the ability to raise their hand can do so. We've got Jane Dunnage coming in asking, will NV work on other charity umbrellas where health is one of their areas, but have a wider brief like National Children's Bureau, Roundtree, Race Equality Commission?
Well, actually, that's a kind of new question to us, Jane. I don't know if you want to sort of follow that up with an explanation of what you're thinking about. I mean, obviously, we make all sorts of partnerships and alliances as we go, but they tend to be focused on health, well-being, and care support and treatment. I'm not sure we've ever been requested by any of those bodies to work with them, but it's entirely possible if it fits our mission. Anybody else have thoughts about that? So Jane's saying it would help to amplify our voice because issues of health do cross those boundaries, which is a fair point. Okay, so we've got 3 questions up at the moment, really, about whether what we're describing in the...
Oh, sorry, I've inadvertently signed Don out, changing back over. Sorry, Don, can you hear me? I signed you out by accident there while changing back to listen only mode.
Yeah.
Okay, sorry.
Okay, you had enough of me already.
Sorry.
So we've got 3 questions up at the moment, really asking whether the stuff that we've described in these slides and in the documents and so on, really feels like the world as you know it. Is the strategic context we're talking about kind of accurate? Does it sound like what's happening around you? Where do you think there might be opportunities for change towards person-centered care? And who would you suggest we work with? So if anybody wants to make a comment back on those questions.
Is there any questions coming in? So yeah, Ian Silver saying that the strategic context is right.
That's good to know. Does it feel right to others? Okay. Michael, do you want to? Shall we move on? I've got a couple more questions I can just flash up so people can have a chance to think about them. And those are, looking ahead. We're trying to look ahead now to 2020 with the business plan. So, what do you think our next steps should be pursuing person-centered care? And the question is, I mean, we bundle a lot of stuff under this person-centered care banner. Is it kind of too much sometimes for our audiences to take in? Should we maybe focus on some aspects of person-centered care more than others? Is it more of a priority to try to get systems of personalised care and support planning in place, for instance? Or should we go all out to spread peer support to all the communities who might benefit from it? So again, I'll just pause and see if any questions or comments come in chat box or raise your hand.
Just to say, we've actually moved away from the raise your hand because I don't think people were enjoying that. So just use the chat box, ask any questions. I think there's some people typing away there. So we've got Ian Silver saying, depends on what you were able to resource. Sometimes a specific focus has more impact, which I think is a fair point. I see Jane Dunnage is typing. If there is anyone who does want to raise their hand, we can go back into the other mode, but it may sign Don out again. So just let us know in the chat box and I can change over.
Okay, we can see that people are typing, so we're just waiting for those comments to come through.
Yeah, we've just got Rachel Warren saying, can you say a bit more about the options for different aspects of person-centered care and what your priorities are?
Rachel, thanks for that question. I think we have carefully avoided prioritizing between different approaches. We've been really trying to get recognition that there are a number of different approaches and they overlap. And sometimes if you just try and bolt on one intervention to a system that doesn't change, it might not get you to where you want to be. At the moment, what's happening is that the things we studied last year in the Realising the Value programme have all been taken up and put into the standard contracts for what we know at the moment as MCPs and PACs, which are the new models of care that are primary and community based. Now, those are going to be the building blocks for the future system as things are planned. They've been retitled accountable care organisations. And we actually did a lot of work with the contracts people. It wasn't the most exciting work, but it was quite significant to get the contracts changed to include that stuff very clearly as requirements. So if you're sitting down planning population health approaches in the next few years and thinking of using one of those organizational forms locally, you will see that you're required to do care and support planning, to make peer support available, to consider education for self-management, health coaching, personal budgets, and so on. There's about 7 interventions, plus to work in a way that's engaged with the community according to the NICE guideline on community engagement. So we're actually have been pursuing a whole package of stuff. I guess the question for the next phase is will that continue to be successful, or should we just pick up on one thing and have a kind of all-out campaign on that? Just say, well, we still want the whole package, but actually the key to it, for instance, is embedding care and support planning. So that would mean we kind of de-emphasize, let's say, self-management education or peer support, and we'd just say, right, we want, primary care to provide, personalized care and support planning for people with long-term conditions. We're going to go all out for that for 2 years. When we talk to professional bodies, that's what we're going to do. When we talk to NHS England, that's all we're going to talk about. So I guess that's the kind of choice that I was hinting at. Excuse me.
Thanks, Don. Jane Dunnage has come back to say there's a danger of confusing people about person-centred care, and it's better to look for policy agreement in principle and then allow interpretation to be arrived at by the individual. Better examples of what could be involved in person-centred care would help to give a better understanding of just one type of person-centred care.
Okay, well that partly goes to the same question. Thanks, Jane. We've had a bit of feedback on that in our previous discussions, which I will come to shortly in another slide. I'm just going to give just another opportunity. Rachel, I don't know if there's anything you wanted to come back on from your question.
Still some people typing there. Just waiting now. Right, so we've got Ian Silvers come in to say, from our perspective, please don't de-emphasize self-management. To be clear from Self-Management UK.
Thanks, Ian. I'll say a bit more about it shortly, but I'm just waiting for others. We're waiting for Rachel.
Yeah.
I think having to type is kind of slowing this down a little bit.
We've got Rachel in now saying thank you. So I suppose it depends on whether you can make more progress by focusing versus key messages of the impact of other important aspects being lost. Sorry, I moved there while I was speaking.
Yeah,
So
yeah,
thank you.
it's a trade-off, Rachel. You're right. I mean, we'll keep considering how we make those trade-offs, but right now it's fair to say, we've just been doing some work on care planning, which is to help shape a standard way of electronically recording people's care plans so that they can sit on health systems and be accessible to any professionals or others who need to access them. And we got some of our members involved in that. We've also changed the care planning questions in the general practice patient survey. So the next time it goes out, it will have new and better questions. I mentioned the work we're doing on peer support.